Hello students, we are about to talk about the assessment and management of patients with endocrine disorder. This is Maria Tucarbo. So we're going to start off with the glands of the endocrine system. The glands of the endocrine system. These glands include the hypothalamus, the posterior pituitary, and the anterior pituitary, a thyroid, parathyroid, adrenals, pancreatic islets, ovaries, and the testes. Next slide. Let's talk about each of these glands. Next slide. First one is hypothalamus. Hypothalamus, very important in the releasing and inhibiting of hormones. Particularly, there are corticotropin releasing hormones, thyrotropin releasing hormones, the growth hormone releasing hormone, gonadotropin releasing hormone, and somatostatin, which inhibits the growth hormone and thyroid stimulating hormone. Next slide. Anterior posterior pituitary gland and the anterior pituitary gland. Posterior pituitary gland is responsible for the antidiuretic hormone, oxytocin as well, which plays a role in the contraction of the uterus, milk ejection, and from the breast. Anterior pituitary hormone, it's responsible for growth hormone, particularly adrenocorticotropin hormone, thyroid stimulating hormone, follicle stimulating hormone in the ovary, in the female, and the sperm in the males. Luteinizing hormone, which helps the corpus luteum in females, secretion of the testosterone in the males, and prolactin, which prepares the female breast for lactation. Next slide. As discussed, the anterior pituitary hormone, again, focusing on a lot of hormones, specifically, FSH, LH, and prolactin. As discussed just previously, in that prolactin prepares the female breast for lactation. Next slide. The thyroid gland has follicular cells, and it helps in the excretion of T3 and T4 hormones. Also increases the metabolic rate, increase the bone and the calcium turnover. It increases the response to catecholamine and the need for fetal growth and development. The thyroid C cells are responsible for calcitonin, which lowers the blood calcium and the phosphorus level. Next slide. Thyroid hormone regulates the serum calcium. Next slide. The adrenal cortex plays a very important role on the mineralocorticoid, which is aldosterone. Aldosterone affects the sodium absorption and loss of potassium by the kidney. The glucocorticoid, the cortisol, which affects metabolism and regulates the blood sugar level. It affects the growth and anti-inflammatory actions, and also decrease the effects of stress. Adrenal androgens are pretty much responsible in helping to convert testosterone in the periphery. Next slide. Pancreatic islet cells, these are responsible for insulin, and also glucagon, which stimulate gluconeogenesis and and also, somatostatin, which decrease the intestinal absorption of glucose. Next slide. Ovaries, hormones that are responsible here are the estrogen and also progesterone. Progesterone is one of the most important hormones in pregnancy because it stops abortion. It's important in the menstrual cycle. Again, it maintains the pregnancy. The testes are the androgens and testosterone. These are the secondary sexual characteristics and sperm production. Thymus releases thymosin and thymopoietin and also affects the maturation of the T lymphocytes. So it's important for you to know those different hormones and the roles that it play. You can review this in your book and part of your A&P text as well. And then you have the pineal. These are responsible for melatonin. It affects the sleep, fertility, and aging as well. Next is the prostaglandin. They work locally and released by the plasma cells that affect fertility, blood clotting, and body temperature. Next slide. So now let's do a little bit of assessment when it comes to the endocrine system. It's important, the nurse, to collect certain information that points to the endocrine system. Such information include reviewing the history, so the energy level, any hand and foot size changes, so you're looking at maybe an excess in growth hormone, headaches, urinary changes, heat and cold intolerance, changes in sexual characteristic, personality changes, and others. In terms of the physical assessments, you're going to look at any appearance, including the hair distribution, the fat distribution, the quality of the skin, the appearance of the eyes, size of the feet and hands, peripheral edema, facial puffiness, and vital signs. These are all going to tell you the different diseases that we're about to talk about today. And in terms of diagnostic evaluation, you want to look at the hormone level, so the serum level of the hormones, and you need to detect in any antibodies against certain hormones. We'll do urinary test that measures products such as norepinephrine and dopamine. Stimulation tests that may be done to determine how an endocrine gland responds to a stimulating hormone, or if the hormone responds, that tells us where the problem is going to lie. Or we can do tests that are looking for suppression, negative feedback that controls the secretion of hormones from, the hypothalamus or the pituitary gland. The pituitary gland is what we refer to as the master gland. Next slide. So now let's start by talking about the disorders of the pituitary gland. And one of these disorders are pituitary tumor, diabetes insipidus, and syndrome of inappropriate diuretic hormone. Let's talk first about your pituitary tumors. The pituitary tumors, there's eosinophilic tumors. They may result in gigantism, which means excess hormone, or acromegaly. But gigantism is seen in younger children before the epiphysis is sealed, because since it hasn't sealed, the kids grow longer or like a giant, versus excess hormone in the adult, because they're no longer getting taller or longer. They have broadening of things, so you see acromegaly. They may suffer from a severe headache, visual disturbances, and classification of the drug or some other endocrine disturbance. Whereas the basophilic tumors, they may cause Cushing's syndrome, features of hyperadrenalism, and you see truncal obesity, amenorrhea, and osteoporosis. Next slide. Well, furthermore, part of these tumors also, what we want to do is make sure that we assess the growth hormone deficiency in children, because if we don't, that may result in primary dwarfism. Your assessment and diagnostic findings for a client that is diagnosed with pituitary tumor, we need to do a history and physical, so collecting all the information we just talked about, and also vision test. We'll do a CT scan, there's MRI, and of course look at the serum level of the pituitary hormones that are secreted. In diabetes insipidus, what you see here is the deficiency of antidiuretic hormone, right? So a deficiency with antidiuretic hormone, so what you see is excessive thirst, because there's large volume of diluted urine. So the patient is losing a lot of fluid. The diuretic hormone is not as efficient. It can occur secondary to brain tumor or head trauma, infection of the central nervous system, and surgical brain surgery or radiation. Nephrogenic diabetes insipidus, that result relates to the failure of the renal tubules to respond to ADH, which can be related to the hypokalemia, hypocalcemia, and medications that the patients are taking, such as lithium. Next slide. Some of the manifestation that you see for diabetes insipidus is excessive thirst, and if you do the urine specific gravity, it would be 1.001 to 1.005. Your assessment finding is, how do we find out what type of issue that is going on? We do something called a fluid deprivation test, and this is where we withhold the fluids for about 8 to 12 hours and weigh the patient frequently. So what happens is the inability to slow down the urine output and failure to concentrate the urine are diagnostic tests, because generally when someone is dehydrated, the fluid is held. So we stop the test if the patient is tachypneic or hypotensive, clearly. What we do is give a drug called desmopressin, and sometimes in hypotonic saline. We monitor the serum and the urine osmolality and the antidiuretic levels. So treatment again is desmopressin that is given. It also can be given IM if necessary, every 24 to 96 hours. We need to make sure that we monitor for lipodystrophy when it's given IM. Can also be given diabenes and thiazide diuretics, right? That's diabenese and thiazide, TIAZID diuretics in a mild disease, as they may potentiate the action of ADH. If the issue is within the kidney, thiazide diuretics, NSAIDs, and salt deprivation may help. Part of what we need to do is to educate the patient about actions of medication and how to administer the meds, and wear a MedAlert bracelet. The next and final pituitary gland disorder is syndrome of inappropriate antidiuretic hormone, that's SIADH. Here what you have is excess antidiuretic hormone, so too much, so which means that the patient is going to retain fluid and develop delusional hyponatremia, if you remember from our electrolyte lecture. Often is non-endocrine in origin. Some of the causes include central nervous system, like head injury, brain surgery, tumors, infection or medication, like phenothiazines and TCA or thiazide diuretics. The meds can either affect the pituitary or increase the sensitivity to the renal tubules to ADH. So management is pretty much to try to eliminate the cause. We can give diuretics, specifically loop diuretics such as Lasix. restrictive fluid, because remember they're holding on to more fluid. Eyes and nose, and weigh them daily and monitor the chemistry, so a complete metabolic panel can be assessed. So what we need to do is restore the electrolyte gradually. Next slide. So thyroid. Thyroid hormone, the thyroid gland, which is located in the neck, secretes T3 and T4. Iodine is needed for the synthesis of the hormone, so excessive will result in adaptive decline in the utilization of the hormone. Thyroid is controlled by the TSH, thyroid stimulating hormone. Cellular metabolism and brain development, normal growth affect every organ in the body. So when the babies are born, we usually will assess for the thyroid level, because not enough thyroid can cause mental retardation. So T3 is 5 times as potent as T4. Calcitonin, which is secreted in response to high levels of serum calcium, increases the deposition in the bone. So when it comes to the thyroid, the job of a nurse to inspect the gland, observe for the goiter, and we can also get orders to check the TSH, the serum T3 and T4. The T3 resin reuptake test is useful in trying to evaluate the thyroid hormone levels in a client who have received, a diagnostic or therapeutic dose of iodine. Estrogen, Dilantin, Tagamet, heparin, amiodarone, PTU, steroids, and lithium, they could cloud the accuracy of this test result. So we need to be mindful of that. T3 is more accurate indicator of hyperthyroidism. Generally, if there is hyperthyroidism, so you will see the T3, T4 will be elevated, and the TSH level would be lower. And if there's hypothyroidism, TSH will be high, and the T3 and T4 will be low. That's what the blood result will look like. All right. The antibodies sometimes are seen in Hashimoto's, Graves, and other autoimmune problems, right? So we can monitor antibodies. Radioactive iodine uptake test, is usually used to help measure the rate of iodine uptake. This patient with hyperthyroidism, usually that exhibit a high uptake, hypothyroidism will be low uptake, right? Thyroid scan can help determine the location, the size, the shape, and the size of the gland. They have hot areas which increase the function, and cold areas, which means there's a decrease in function. They can also help to try to diagnose the issues that we have. All right. And for some of the nursing implication when it comes to the thyroid condition, it's important for the nurse to be aware of the meds that the patient is taking that can affect the accuracy of the test, such as the align, like I previously just discussed. Also be aware if the patient is taking multivitamins and other food supplement. Okay, so now let's talk about hypothyroidism. Hypothyroidism is most common cause is Hashimoto's thyroiditis. It's common in those previously treated with hyperthyroidism. Usually atrophy of the gland with aging can also cause hypothyroidism. Medication like lithium iodine combined and antithyroid meds can cause hypothyroidism. That makes sense. Radiation treatment to the neck, to the head and neck, can also cause it. Infective diseases such as scleroderma can also cause hypothyroidism. That's SCLERODEMA. Iodine deficiency or excess, can cause thyroid problems. Hypothalamic and pituitary abnormalities. Remember, the pituitary gland has stimulates certain glands to produce that there is a deficiency or excess. So if there's a problem with the pituitary gland, that signal doesn't happen, so you see the result. More common in women, and especially those over the age of 50. So what are some of the manifestations that the patient will show you when they have hypothyroidism? So it could be mild symptoms. So myxedema, mild to like severe. So myxedema is accumulation of mucopolysaccharide in the subcutaneous and intestinal tissue. It's the extreme form of hypothyroidism, and it could progress to shock. All right, and what you see, the signs and symptoms are there's fatigue. So when you don't have enough thyroid hormone, just think about what it does. It helps with metabolic rate. So there's fatigue, there's hair loss, there's dry skin, there's brittle nails, numbness and tinglings of the finger, amenorrhea, weight gain, decreased heart rate, temperature, cognitive changes, elevated cholesterol level, constipation, and hypothyroidism. So pretty much when you're looking at most of the symptoms, you're seeing that with hypothyroidism, most things are lower down, because it's slower, with the exception of things that go up, the bad things. So your weight go up, your cholesterol level go up, but everything else is going down. So your heart rate is not tachycardic, it's bradycardic. You're not having diarrhea, you're having constipation. So things are slowing down because the metabolic rate is slower. All right? And so clearly we need to try to replace the hormone level that the patient doesn't have. So levothyroxine is the preferred agent, and the dosage is based on the TSH level. Angina can occur when thyroid is replaced, so we need to monitor the patient closely for cardiovascular symptoms, and usually we want to start them, especially if they have pre-existing cardiac conditions, so we want to start them at a low dose. Hypnosis and sedative may have profound effect on the sensorium, on the sensory, okay? So management of myxedema, the severe case of hypothyroidism, which can progress to shock, so we need to continuous replacement of fluid and glucose to restore to normal glycemic level, and avoid any rapid overheating due to increased oxygen demands. But we need to make sure that the patient is warm. May give them, the thyroid hormone levothyroxine intravenously with the recovery, and then we'll modify the activity, high fiber diet, and follow up with the patient. And then you have the hypothyroidism, and it's an extreme case of hypothyroidism. In this case, it's called Graves' disease. The causes is thyroiditis, so an inflammation of the thyroid gland. It could be, someone who's taking excessive amount of thyroid hormone, so treating the patient with thyroid replacement when they have hypothyroidism can put them at risk. So abnormal output of immunoglobulin is also a cause, and it's more common in women. So what are some of the manifestations that a patient may have who have hypothyroidism? Remember, with hypothyroidism, everything slows down. Hyper, it's faster. So thyroid toxicosis. So they are nervous, they are irritable, apprehensive, palpation, heat intolerance, not cold intolerance. Their skin is flushed and tremors. Possible exophthalmos. So the eyes are protruding. So we got to make sure that we try to maintain and protect their eyes. They have there's increased sensitivity to the catecholamines. That's why everything is a little higher, right? And usually can occur after radiation or presence of a tumor. Your diagnosis and assessment, usually there's a thyroid thrill and a bruit if it's listened to. The thyroid gland may be elevated when you palpate. And decrease in the TSH. So if you do the blood work, the TSH will be low, and there's the free T3 is increased. And if you do the thyroid reuptake, you will see an increase in reuptake versus the decrease in hypothyroidism. And then in terms of management, they have excess. If the reason why they have excess thyroid thyroid hormone, then we want to reduce the dose, right? But we can do use radioactive iodine and anti-thyroid meds or surgery. This patient is tachycardic, so we can use drugs such as beta blockers, like we talked about in our cardiac lecture. Can relapse with the anti-thyroid meds, clearly. Other pharmacological therapy is radiation, like I said, with administration of radioisotope iodine 131. Initially, we may cause an acute release of the thyroid hormone, and then we should monitor them for the thyroid storm. Signs and symptoms of thyroid storm include high fever, tachycardia, delirious, chest pain, dyspnea, palpitations, weight loss, diarrhea, and abdominal pain. Remember, with hypothyroidism, there's weight gain. These guys are weight loss. And so we have to manage the thyroid storm. So oxygen therapy, IV fluids with dextrose, hypothermic measures because they're heat, steroids to treat the shock or adrenal deficiency, and iodine to decrease the output of T4, and beta blocker, PTU or tapazole to impede the formation of the thyroid hormone and block the conversion of T4 to T3. The different drugs of anti-thyroid drugs, again, there's PTU, so you should look at that, and pretty much is blocking the synthesis of the hormone. Tapazole, it blocks the synthesis of hormones. It's more toxic than PTU. Sodium iodine, it suppresses the release of the thyroid hormone. Saturated solution of potassium chloride, that's SSKI, that would help suppress the release of hormones and decrease the vascularity of the thyroid. It can stain the teeth, so you need to worry about that. Dexamethasone, which we'll use to suppress the release of the thyroid hormone. Also, other treatment management will be surgery. Surgery is preserved or reserved for special circumstances, when there's a very large goiter, or those who cannot take the anti-thyroid medicine, or who need rapid normalization. So it's not just given, to everyone. So subtotal thyroidectomy, so removing the thyroid gland. So before surgery, we usually give, PTU until the signs and symptoms of hypothyroidism have disappeared. All right, and then iodine may be used to decrease the vascularity too. So you don't want to just go remove the thyroid. We need to make sure that there are no signs of hypothyroidism, and also, that there's less vascularity of the thyroid gland. So what are some of the nursing management for the patient who has hyperthyroidism? So reassurance is really important. Emotional reaction experience. We may need eye care if they have exophthalmos. So their eyes are protruding. Look that up. That's EXOPHTHALOMOS. Maintain normal body temperature because of the heat intolerance. Adequate caloric intake because their metabolic rate is really high. Managing the potential complications such as dysrhythmia and tachycardia. They give a beta blocker. Educate them about potential signs and symptoms of hypothyroidism following the treatment therapy. So remember, when you treat, usually the opposite, you should be ready to assess for that. Next slide. So now we're talking about parathyroid gland and some of the conditions of this gland. Parathyroid maintains sufficient serum calcium levels. Excess calcium can bind with phosphate and participate in the various organ, right, which can cause pancreatitis. Hyperparathyroidism will cause bone decalcification and development of renal calculi. So if you have a lot of calcium, you're prone to stones. It's more commonly seen in women, and you have secondary hyperparathyroidism, which occurs in those that have like chronic renal failure, renal rickets secondary to excess phosphorate retention. Um, so some of the patients that have manifestation of hypothyroidism, some people may be asymptomatic, right? So no symptoms at all. But if they have symptoms, it could be apathy, fatigue, muscle weakness, nausea, vomiting, constipation, hypertension, and cardiac dysrhythmia, right? There may be excess calcium in the brain, which can lead to psychosis, renal lithiasis, which can lead to renal damage and even failure, demineralization of the bone with back and joint pain, pain on weight bearing joints, and pathologic fractures. Okay, so fractures. Peptic ulcer and pancreatitis can also occur. All right, so there are some assessment and diagnostic findings. Usually, you will see persistent elevated in calcium levels. That makes sense. Elevated serum parathyroid hormone. You will see the bone studies will reveal decreased density, because decreased density. Double antibody parathyroid hormone test is used to distinguish between a primary type of parathyroid versus that of a malignancy. Other tests that could be done are ultrasound, MRI, a biopsy, which can also use to localize the cyst, adenomas, or hyperplasia. So management includes, just treating the hyperparathyroidism is surgical removal, right? Hydration is really important, necessary to prevent the kidney calculi, so the kidney stones. Avoid thiazide diuretics as they decrease the renal excretion of calcium, right? So increase mobility, because mobility will promote the bone retention of calcium. Avoid restriction or excess calcium in the diet, because you have too much. Fluids and prune juice and stool softener to prevent constipation. And of course, watch for signs. Once they remove parathyroid hormone, the parathyroid gland, then you're at risk for post-surgical hypothyroidism, right? I mean, a hypoparathyroidism. So we have to watch for signs of tensioning. So there's numbness, tingling, as well as cardiac dysrhythmia and hypotension, right? And then you should be cautious as we should be cautious about hypercalcemic crisis. Hypercalcemic crisis. This is usually seen with levels that is greater than 15 milligrams per deciliter. Hypercalcemic crisis results in life-threatening neurologic, cardiovascular, and renal symptoms. So it's bad stuff. So what do we do when someone has too much calcium? So hydration is important. Loop diuretics to promote excretion of the calcium. Phosphate therapy to promote calcium deposition in the bone and reducing the GI absorption of calcium. Given calcitonin, to decrease the serum calcium level quickly. Right, calcitonin. All right, and so now we're talking about hypoparathyroidism. So this is, let's talk about the patient who has removed their parathyroid. So this person will have hypoparathyroidism, right? So it's seen again most commonly after you remove the parathyroid, and usually after a surgery, right? So if they do a surgery of removal of the thyroid gland, the parathyroid are under that, so they would have removed the parathyroid hormone, and that's usually the most reason why you see hypoparathyroidism is because they remove the thyroid gland, and when they remove that, they remove the parathyroid hormone, right? So, or following radical neck surgery, right? So you see the deficiency of parathyroid hormone that results in the increased bone phosphate and decreased blood calcium level. If there's an absence of parathyroid hormone, there's a decreased intestinal absorption of dietary calcium and decreased reabsorption of calcium from the bone and through the kidney tubules. So it's important. What are some of the clinical manifestations that you will see with hypoparathyroidism? So irritability of the neurovascular system, that's what you're going to see. You're going to see neuromuscular system signs and symptoms. So tetany, that's Tetany. So what happens is that you're seeing hypertonic muscle contraction, right? You're seeing numbness and tingling, cramps in the extremities, laryngeal spasm, bronchial spasm, and seizures activity. So what are some of the signs and symptoms? Remember we talked about the calcium, hypocalcium level and the electrolyte. So you see the Trousseau sign and the Cherinsky sign that we talked about. So Trousseau's, you check it with the blood pressure cuff versus Cherinsky sign where you tap over the facial nerve, which causes spasm of the mouth, the nose, and the eye. And if you do the labs, you will see the serum level will be 5 to 6 deciliter, milligram per deciliter or lower. The serum phosphate level will be decreased as well. Right? So what do we do in terms of management of someone who has hypothyroidism? Well, we have to restore the calcium level to the normal level, which is 9 to about 10. We may need to give them IV calcium gluconate for immediate treatment, and use of parathyroid hormone IV, to preserve for extreme situation, right? Because of the probability of allergic reaction. We're going to monitor the level of the calcium. We may need bronchodilators or even a ventilation for assistance. Diet that is high in calcium and low in phosphate, and thus avoid milk product, egg, and spinach. Next slide. Also, we got to keep, when you're treating, you got to keep calcium gluconate at the bedside, and ensure that the IV, there's access. We're monitoring the cardiac rhythm, and we are providing post-operative when the patient undergo this thyroid surgery, so we watch for signs and symptoms, that can, show that the patient may have hypoparathyroidism, such as tetany, seizures, and respiratory difficulty. Next slide. Before I speak about the corticosteroid therapy, let's talk about adrenals. Adrenals, what you have is pheochromocytoma, that's Pheochromocytoma. This is usually a benign tumor that sits on the adrenal gland. The adrenal gland sits on top of the kidneys, right? This can occur at any age, but it's usually seen between the age of 40 and 50. It can be familial, and 10% of these are malignant. Remember, there's different types of hypertension. We talked about primary versus secondary. Secondary, we know the cause. This can be a reason why someone has an elevated blood pressure. And so it may be associated also with the thyroid carcinoma or parathyroid hyperplasia or tumor. Clinical manifestation that you see is that the patient is again hypertensive, because of releasing of the catecholamines, headache, diaphoresis, palpitation. may have hyperglycemia related to the excess epinephrine secretion. Tremors, flushing and anxiety, blurred vision, feeling of impending doom, right? And the blood pressure usually when it's taken is exceeding 250 over 150, right? So what are some of the nursing assessment and diagnostic finding for adrenal phenylcytochrome adrenal tumor is usually there's hypertension, like I said, headache, hypermetabolism, hyperglycemia, urinary catecholamines are seen, serum epinephrine and norepinephrine levels will be elevated. So here it's important for us to avoid caffeine, tea, banana, chocolate, vanilla, aspirin, all of this stuff 24 hours before the urine testing. Clonidine suppression test in a normal individuals will block the catecholamine release, not in this case when these guys have this condition. We may do imaging tests just to make sure that we visualize what's happening, the tumor or kidneys or whatever else that is going on. Management is bed rest, elevating the head of the bed. These guys are usually in the ICU. They are getting calcium channel blockers, beta blockers. There could be surgical management to manipulation of the tumor, which can cause more, excessive release of the catecholamine. So we have to be very careful of that. Steroid therapy may be used, and hypotension and hypoglycemia can occur post-operatively. Another problem that can occur with the adrenal gland is Addison's disease. Addison's disease, what the problem is, adrenal cortical insufficiency, and it could be autoimmune or idiopathic atrophy of the gland. It can be caused by inadequate secretion of the hormone from the pituitary gland, and ACTH, or the therapeutic use of steroids. So this is one of the reasons why we don't want to abruptly stop the steroids, right? So clinical manifestation: weakness, anorexia, dark pigmentation, hypotension, hypoglycemia, low sodium levels, high potassium levels. Again, the cause, it may result in adenosine crisis. So the adenosine crisis is circulatory shock. So this patient, they are polar, apprehensive, weak, rapid pulse, rapid respiration, low blood pressure, headache, nausea, abdominal pain, diarrhea, and it can be brought on by overexertion, exposure to cold, acute infection, decrease in sodium intake. And your assessment findings are, if you do early morning serum cortisol and plasma ACTH, they usually perform. This would help us distinguish between the primary and secondary adrenal insufficiency. In primary, what we have is elevated ACTH, right, and low normal cortisol level. If the adrenal cortex is not stimulated by the pituitary gland, then a normal response to the dose of ACTH is usually seen. So the blood sugar levels and electrolyte levels are also done. So what we want to do is to restore the circulatory status. So fluids, give them steroids, and we may need to give them antibiotic if the cause was precipitated by an infection. And we may also need, we may need a lifelong steroid therapy and mineralocorticoid therapy. We may need additional salt intake. We need to check their daily weight and make sure that they are aware of any stresses that can precipitate the crisis. It's important that they wear med alert, to notify, paramedics or someone who needs help for them. And then you have Cushing's syndrome, right? Cushing's syndrome results from excessive adrenocortical activity, right? So it may be related to excess use of the steroid therapy, medication, or due to hyperplasia of the adrenal cortex, right? Oversecretion of corticosteroids can also be caused by the pituitary gland. So Cushing's syndrome. So you see this, we always talk about steroid therapy. One of the complications we see from that, or what we should monitor for, is this Cushing's syndrome. So what are some of the manifestations of Cushing's syndrome? There's cataract, there's glaucoma, there's hypertension, heart failure. You see truncal obesity, moon face, buffalo hump, sodium retention, hypokalemia, hypercalcemia, negative nitrogen balance, alter calcium metabolism, decreased inflammatory response, impair wound healing, increased susceptibility to infection, osteoporosis, compression fracture, thinning of the skin, striae, acne, mood alteration. So assessment and diagnostic, usually they will give an overnight dextromethasone suppression test, and usually it's used to diagnose. And it's usually given at 11 p.m. and the cortisol level checked in the 8 a.m. So what you see is when there's suppression of cortisol to less than 5 milligram, it indicates normal functioning. All right, normal functioning. So administration of the plasma ACTH, in conjunction with the dextromethasone suppression test, would help us distinguish primary versus ectopic site of ACTH. The MRI, CT scan, and CT scan can also detect, tumors or any adrenal or any pituitary problems. All right. If the issue the patient is having is from the pituitary source, then we need to do surgery, right? Surgery, transsphenoidal surgery. Radiation of the pituitary gland may be also appropriate. Adrenalectomy may be needed in case of adrenal hypertrophy. All right. Temporary replacement therapy with hydrocortisone is needed. Adrenal enzyme reducers may also be indicated if the source is ectopic or inoperable, right? Example of that is ketoconazole. That's ketoconazole. If if the cause is related to excess steroid therapy, then we need to tape it off slowly, right? Tape it off to a minimum dosage that is appropriate. You cannot stop abruptly, right? Cannot stop abruptly. All right, so again, steroid therapy, we just talked about it, but there's many different steroids. They are used for a lot of things. The number one drugs for anti-inflammatory. You've heard of prednisone, you've heard of cortisone, you've heard of betamethasone. So they are drugs that are used to help with some type of inflammatory process, such as rheumatoid arthritis. They can be used for asthma to decrease the inflammation. They could be used for MS. It could be used for COPD. They could be used for autoimmune diseases like lupus and other types. They could be used for dermatological conditions. So it's pretty widely used drug. And for dosing, we try to start with the lowest dose and limit duration because of the adverse effects that are associated with it. The best time to give it It's early morning between 7 and 8. We need to make sure we taper it off to allow the normal return of the adrenal function, right? You taper it off. If you stop abruptly, then it will cause the adrenal crisis, right? So what are the side effects of steroids? There's hypertension, there's thrombophlebitis, there's accelerated atherosclerosis, there's increased risk for infection, there's glaucoma and corneal lesions, there's muscle wasting, there's poor wound healing, there's osteoporosis, there's pathologic fractures, there's hyperglycemia, there's steroid withdrawal syndrome, there's Cushing's syndrome, remember that, which has the moon face, the weight gain, the acne, the stray hairs, and so forth. So it's important for you to understand steroid and monitor for the adverse effect that goes with it. Next slide. So now we're going to start our lecture with diabetes. Yeah, so we're going to talk about diabetes. Next slide. So diabetes. Normal insulin metabolism is very important to understand before you can talk about diabetes. Insulin is produced by the beta cells in the islets of Langerhans. It's like 1,000 cells. What happens is that insulin is released continuously into the bloodstream in small increments with larger amount released after food intake. It makes sense. It stabilizes the glucose level to the normal range, which is 70 to 120 milligram per deciliter. The average daily secretion is about 0.6 units per kilogram per body weight. So, you got to look at that in terms of, administering your insulin. Next slide. So this graph is really nice because it's just giving you pretty much what we just described. After a meal, you expect the blood sugar to go up, right? So it's lower, and then after a meal, the insulin level go up. So you see the plasma insulin per unit is lower in the mornings, and then at 8 a.m., the person takes it. It's lower, but then when the person eats, look what happens to the amount of insulin that is released. So it goes up. So it correlates with your meal, and that's what needs to happen, when someone is normal. However, this process is impaired with someone that has problems with the with the pancreas. Next slide. So this is blood sugar homeostasis again. So if we have a high blood sugar, what happens is the pancreas go to work and releases insulin, right? And what happens after that is released. The pancreas say, you know what, cells need to be taken up. The cells take up the glucose from the blood, and then the liver also goes to work and produces glycogen. And then what happens is the end result is the blood sugar falls. And then when it's lower, the pancreas releases glycogen, and which breaks down glycogen, right? And then the blood glucose level will rise. So this happens constantly throughout the day. All right, next slide. So insulin, in terms of regulation, it decreases the glucose in the bloodstream. That's what we just talked about. Pretty much the graph that you saw. Insulin level goes after a meal, and it stimulates the storage of the glucose as glucose in the liver and the muscle, and then it inhibits the glucogenesis, right? It enhances the fat disposition and increase protein synthesis, and then promote the glucose transfer from the bloodstream across the cell membranes to cytoplasm of the cell. So it happens very fast without, involuntarily. So you don't have to control it. It happens involuntarily, right? Stress places emotional or physical stress can increase the blood sugar level. Right? So we know that. Medication can potentiate hypo or hypoglycemic effect. We know that there's certain drugs that can do that. Exercise has an effect on your blood sugar regulation, right? So that's why even individuals who are diagnosed with diabetes, if they exercise, their drug therapy may be lowered, right? Counter regulation hormones, so opposite effect of insulin, so increased blood glucose level, provide a regulated release of glucose for energy and help maintain normal blood glucose level. Examples of these hormones, we talked about some of them, is glycogen, epinephrine, growth hormone, and cortisol. Next slide. So, just finished talking about this, but let's go to the next slide. Now we're about to start our discussion on diabetes, right? Diabetes is a chronic multi-system disease related to many different things. It could be abnormal insulin production or impaired insulin utilization, or both, right? It is multi-system because it affects all the system, and this is why we monitor the complications that clients may experience when they have diabetes, right? So abnormal insulin production, it's not producing enough. Impaired utilization, the beta cells can be completely destroyed, right? The beta cells can be completely destroyed, or insufficiency amount, so that's why the complications, some of the complications you're going to see, you notice the difference in that. So it's the beta cells that we're talking about in the pancreas, right? So if someone doesn't have a pancreas, then we're gonna have this problem, right? And so we should be thinking, it's insulin, abnormal insulin. So there's different types of diabetes. Clearly, there's type 1 and there's type 2. Type 1, there is beta cells not utilization, not working, versus insufficiency in type 2. You tend to see type 1 younger children, younger versus adult onset diabetes. Not to say that you're not going to see type 2 diabetes in the young and type 1 diabetes in the older folks. Yes, you can, because autoimmune can cause the beta cells to stop functioning also. Next slide. So diabetes, the leading cause is end-stage renal disease and blindness and non-traumatic lower limb amputation. Absolutely. Cardiovascular disease, right? Major contributing factor, heart disease and stroke. Next slide. 73% of adults with diabetes have hypertension, right? 23.6 million people with diabetes in the United States, and 41 million people are pre-diabetic, right? So pre-diabetes. Next slide. All right, so I talked, just briefly, the two types of type 1 and type 2, but there's other types of diabetes too. Gestational diabetes, this is diabetes that is seen with a pregnant woman. Gestation happens during pregnancy, but it should resolve after the pregnancy. However, these individuals have a risk for type 2 diabetes in later years. Pre-diabetic and secondary diabetic. So a secondary diabetic, for example, is someone who's taking steroids, right? They weren't diabetic, and so now their blood sugar is elevated. And a pre-diabetic is someone whose blood sugar is lingering in the lower type. So now let's talk about each one of these diabetes. Next slide. Okay, so type 1, immune-mediated diabetes mellitus, right? That was formerly known as juvenile onset or insulin-dependent diabetes. Most often seen in people under 30 years of age, like I said. The peak onset is between 11 and 13, but type 1 can be seen in the older adults as well. Next slide. The end result of long-standing processes, progressive destruction of pancreatic beta cells by the body's own T cells. So autoimmune. So autoantibodies causes a reduction of 80 to 90% of the normal B cell function before manifestation has occurred. Right? So the destruction is taking place and you don't even know that it's taking place. And so this is why insulin is needed for type 1 diabetes. Next slide. All right. So what are some of the causes? Well, there's lots of theories, which link to single or combination of multiple factors, such as genetic, autoimmune, viral, or environmental factors. All right. So generally, when something is autoimmune, you really don't know. So there's, theories to suggest otherwise. Next slide. So long preclinical period, usually, right? So there's antibodies that are present for months to years before, like I said, the symptoms even occur, and manifestation develop when the pancreas can no longer produce insulin, right? So when it's completely stopped, and that's when you see the rapid onset, those 3Ps, right? And because these guys, the pancreas cannot make any more insulin, they will need insulin for life. For life, and insulin, not oral pills. All right, next slide. So history of recent sudden weight loss. Usually they would, they come in, they tell you about, sudden weight loss. These guys are usually thinner. You see the classic sign of diabetes, the 3Ps: polyuria, polydipsia, and polyphagia. There's hunger, urination, right? Weight loss, weakness, and fatigue. Next slide. So let's talk about the lack of insulin and what causes it, which shows you the signs and symptoms that the patient have. So the glucose molecule accumulates, right? So glucose, you need it. So you have glucose, and what happens is, you have a high level of glucose. That's the term hyperglycemia, right? So when you have hyperglycemia, you're going to have hyperosmolality, okay? Hyperosmolar, there's a lot of sugar, right? So there's drawing of water from the intracellular space into the circulation, right? So this increases the blood volume, which increases the renal blood flow. And when there's increase in urine blood flow, it acts as a diuretic. So diuretic has an outcome, and the outcome is to diurese. So you see polyuria, one of the first P's. All right. Next slide. So when the blood sugar level exceeds the renal threshold for glucose, which is usually about 100 and above 180, the glucose is excreted in the urine. So you're seeing urine glucosuria. The decrease in the intravascular volume, right? Because remember, you're pulling out the fluid. Remember, there's a shift. So that decrease in the volume increases, and the increase in the urine output causes dehydration. When you're dehydrated, the thirst sensors are activated. That tells the patient you got to drink. Polydipsia. Increased amount of fluid. Polydipsia. Okay, next slide. So because the glucose cannot enter the cell without insulin, right? Because you have all the sugar, but it can't enter because there's no insulin. So the energy production decreases. And then when that decreases, it stimulates hunger. I gotta eat. So guess what? The person wants to eat more food. Polyphagia. Right? Next slide. So there's weight loss. And so you see weight loss acute because of loss of water, glycogen, triglyceride stores. For the chronic, there's decrease in muscle mass. You have blurred vision because of the effect of hyperosmolar fluid on the lenses and retina. Fatigue, malaise, and dyspnea because of the decrease in blood volume and potassium. Postural hypertension, and increase in protein catabolism. So if you don't have sugar to use, you're going to go and start taking other things. There's fat, there's protein. All right, there's fat and protein. We're going to talk about these complications later. So you got to treat it. If you don't treat it, that's what's going to happen because the body needs energy. So carbohydrate is the primary source of energy. And if we don't have it, then our body's going to try to find it elsewhere. All right? Next slide. Type 2 diabetes is our next topic. This is the most prevalent type of diabetes. Over 90% of clients with diabetes are type 2. Usually occurs in people over 35 years of age, but that doesn't mean it doesn't happen younger, right? 80 to 90% of patients are overweight, right? Versus type 1, underweight. Next slide. All right, so type 2, the prevalence is with age, there's genetic basis, and it's greater in certain population or ethnic groups. The rate is high in African Americans, Asian Americans, Hispanic Americans, and Native Americans. Native Americans and Alaska Native have the highest rate of diabetes in the world. All right, next slide. So what happens with type 2 diabetes here? So here the pancreas continues to produce some insulin, but just not enough. Not enough or poorly utilized by the tissue. Right? Not enough or poorly utilized by the tissue. Next slide. And so what are some of your manifestation? Obesity, abdominal or visceral. So the most powerful risk factor. Genetic mutations, so which leads to increased insulin resistance and increased risk for obesity. Next slide. Etiology and pathophysiology. So what happens is there's insulin resistance, right? So when there's insulin resistance, the body tissues do not respond to the insulin. Makes sense, right? And the insulin receptors either is unresponsive or it's not insufficient in a number, which would then result in hyperglycemia. Or the pancreas decrease the ability to produce insulin. The beta cells are fatigued from trying to compensate, and the beta cells, the mass is lost. Or inappropriate glucose production from the liver. Right? Remember how that normal insulin, release, what happens? So the liver's response of regulating the release of glucose is, hazardous. It's not considered a primary factor in developing, type 2 though, diabetes. Next slide. So individuals with metabolic syndrome, right? Syndrome X, they call it. These individuals are those that have increased for developing type 2 diabetes. And these metabolic syndromes, there are certain things that they're looking for, and if you have these, then you have a higher risk of developing type 2 diabetes. So the cluster of abnormalities that they look at, tells you that you have cardiovascular disease and diabetes. These are the people that have elevated insulin levels, those that have increased triglyceride, and LDL, so bad cholesterol, and those that have low levels of good cholesterol, and those that are hypertensive. So if you have these, then they'll say, okay, this person has a higher risk. So the physicians are monitoring the client. All right. The risk factors, again, others are central obesity, those who have sedentary lifestyle, those who are in urban and certain ethnicity, like we talked about, the Native Americans and the Alaska natives. Next slide. The onset of diabetes. So it's usually gradual, right? The person may go for many, many years undetected hyperglycemia because the pancreas is still trying to cope. What you see is osmotic fluid and electrolyte loss from the hyperglycemia, and they become very severe, leading to hyperosmolar coma. Next slide. So they may have non-specific symptoms, whereas type 1 have the classic symptoms of diabetes, right? So these guys may just be tired. They may have recurrent infection, recurrent vaginal yeast infection. They may have prolonged wound healing and visual changes. All right, so they're not classic, but they could have those other symptoms. Next slide. So the pre-diabetic, these are individuals that have impaired fasting glucose. So usually the glucose level is greater than the normal, so greater than 100, but less than 126. Right? They're pre-diabetic. There's impaired glucose tolerance. So if you do the 2-hour plasma glucose, it's higher than normal, between 140 and 199. Next slide. This is just showing you pretty much what is considered a pre-diabetic, someone who has a blood sugar that is greater than 126 versus those who are a diabetic. So pre-diabetes versus a diabetic, right? Fasting blood sugar, oral glucose tolerance test. So PFG, two tests that are used, or the oral glucose tolerance test. So the fasting blood sugar, they fast and we draw the blood. And a diabetic, it's greater than 125. Right? If you're pre-diabetic, you're in the yellow zone. Right? So the red zone, when you do the fasting blood sugar, that's the finger stick. The fasting, they draw the blood. The red tells you you're diabetic. So the blood sugar is greater than 125. If you're less than 126, then you're pre-diabetic, you're in the yellow zone. And if you're less than 100, you're considered normal. And then you do the oral glucose tolerance test, and here you drink it, and then they take your blood level. And you're diabetic if it's greater than 200, and you're pre-diabetic if it's less than 200 but greater than 140. And if you're less than 140, you're normal. All right, next slide. All right, so pre-diabetic, there's not much, it's not high enough for diabetes to be diagnosed, right? It makes sense, right? So this increased risk, these people have to develop in type 2 diabetes. There's no preventive measures taken usually. If there's no preventive measures taken, they would develop diabetes in about 10 years, right? Long-term damage already occurring are the heart and the blood vessels, usually present with no symptoms, right? So we need to watch for signs that indicate that the patient is diabetic, polyuria, polyphagia, and polydipsia, or other signs and symptoms that a type 2 diabetes will probably have, the yeast infection, the wound that doesn't heal, fatigue, just not feeling well, right? Next slide. Gestational diabetes is diabetes, like I said, that occurs during pregnancy. It's usually every pregnant woman, usually by the 24 to 28 weeks gestation, we give them a glucose tolerance test that they take, right? Usually back to normal after 6 weeks postpartum. Because insulin is a growth hormone, the kid can get large, and so these guys usually have an increased risk for C-section because of the microsomia, right? And other complications to the baby, perinatal death, and neonatal complication. There's increased risk for developing type 2 in about 5 to 10 years, right? The main therapy is nutritional. They monitor the blood sugar, and if we have to treat with drug, the only drug that can be given is insulin, not the oral drugs. Right? Next slide. There's 4 methods of diagnosing diabetes, right? You can do the hemoglobin A1C, gives you an average, and it really will help also with compliance level. So hemoglobin A1C that's greater than 6.5% is considered diabetic. Fasting blood glucose level greater than 126. You remember that little chart that we showed? That's the two different ones. You have the red, the yellow, and then the green. Random or casual plasma glucose measurement greater than 200. So if somebody just walks into the office, they're not, we haven't told them to fast, and they complain of other signs and symptoms, then we can, and if their blood sugar comes back greater than 200, you could say that they're diabetic, right? 2-hour oral glucose tolerance test, and if the level is greater than 200, using a glucose load of 75 grams. All right, so with the pregnant women, we give them 50 grams. Here we give 75 and then measure the glucose level. And if it's greater than 200, they're considered diabetic. Next slide. All right, so again, hemoglobin A1C, again, useful in determining the glycemic level over time. So it's like an average of 90 to 100 120 days. ADA recommends to diagnose. It shows the amount of glucose attached to the hemoglobin over the RBC life. Ideal goal is 6.5, like we said, but the American College of Endocrinology is saying it should be less than 6.5. Normal A1C reduces, the complication of diabetes, retinopathy, nephropathy, and neuropathy. Next slide. So now we're talking about the complication of diabetes, retinopathy, neuropathy, nephropathy, and other cardiovascular. So it affects all the system pretty much. Retinopathy, cataract, glaucoma, and blindness. In the brain, there's stroke, there's hypertension, there's arteriosclerosis, there is gangrene because of neuropathy, gangrene. So, erectile dysfunction, infection, neuropathy, neurogenic bladder. So it really, really is a multi-system disease. Remember at the beginning of the lecture, we talked about it being a multi-system disease. Next slide. So let's talk about the different types. All right, so angiopathy, right? So you have like neurovascular problems, right? There's some neurovascular problems, right? So the disease of large and medium cell size blood vessels, so the brain, the peripheral vascular disease, patient with diabetes, again, we screen them regularly. Every 6 months to 1 year, they should be coming, and it's important for them to have, a good control of their diabetes, monitoring the blood sugar at home to help reduce the risk. And then, next slide, you have the conditions that may affect the smaller vessels, right? The smaller vessels, so thickening of the vessels, membranes, and the capillaries and arterioles, and it's due to the fact that there's chronic hyperglycemia, right? This is specific to diabetes, unlike microvascular. Microvascular can be caused by other things, right? The most areas that are noticeable affected are the eyes, retinopathy, kidney, nephropathy, and skin. All right. Clinical manifestation usually appears after 10 to 20 years of diabetes. Next slide. So, diabetic nephropathy, microvascular damage to the retina. Again, most common cause of new cases of blindness in people 20 to 74 years of age. That's why we encourage annual dilated eye exam. So to go in and look in the eyes. Next slide. So non-proliferative diabetic neuropathy is the most common form. So you see is partial occlusion of the small vessels in the retina, causes development of microaneurysm, capillary fluid leak out, so you end up with retinal edema and eventually heart exudates, hemorrhaging, all of this leading to, other things. The outcome is blindness. Next slide. So here you have the proliferative type of retinopathy. It's the most severe form. It involves retina and varus and capillaries become occluded. The blood forms new blood vessels. Vessels are extremely fragile and hemorrhage easily, and the retina end up detaching. Next slide. So you have nephropathy. This is associated with damage to the small blood vessels that supply the glomeruli of the kidney, so which leads to end-stage renal disease. So this is why these guys are screened with microalbumin, so the urine sample, 24-hour urine sample, the serum creatinine level. So creatinine level will tell you about the kidney failure. So it's really, really important for them to have tight control of their glucose, monitor their blood pressure, make sure that it's under control. They put them on the blood pressure drug, the angiotensin converting enzyme, that's the ACE inhibitors, so it's used even when they're not hypertensive. So because it's protective mechanism, it protects their kidneys. Next slide. And then neuropathy. 60 to 70% of clients with diabetes have some degree of neuropathy, right? The nerve damage due to metabolic dearrangement of the diabetes. So sensory versus autonomic neuropathy here, right? So you see sensory versus autonomic. Let's talk about each one. Next slide. So sensory, feeling, right? So feeling of the sensation, the feeling of it, right? So it's important here for tight control of the blood sugar, topical creams, tricyclic antidepressant can help. Selective serotonin and norepinephrine reuptake inhibitors, anti-seizure meds can help with this type of neuropathy. Next slide. So distal symmetry. So it's the most common form of the sensory type, where the distal parts, the hands and the feet bilaterally, are involved. So there's the loss of sensation, abnormal sensation, pain, and paresthesia. Okay, and paresthesia. Next slide. Usually the patient is going to complain of the symptoms and usually worse at night. The foot injury and ulceration can occur without the patient having pain. So this is why it's so important for us to teach our diabetic client to inspect their feet and not walk barefoot. Okay, next slide. This is an example of it. Look at the neurotrophic ulceration, right? They cannot feel. He didn't feel that. Okay, next slide. The difference here, we're talking about an autonomic neuropathy. This is different because it's not just a peripheral. This affects all the body system, including gastrointestinal. So they're going to have delayed gastric emptying, cardiovascular, including the heart. So these are the guys when they have chest pain. Like how somebody's having chest pain, and that I'm having chest pain. So an MI. These guys don't even know that they're having chest pain. So they have silent heart attack without knowing. So it's really, really dangerous. So it affects the cardiovascular system. It affects the sexual function, right? Erectile dysfunction, and the bladder, neurogenic bladder. So it's really, really issues with this. All right, next slide. So complication of the foot and lower extremities. So foot complication most commonly cause for hospitalization in patients with diabetes. That's correct. It's the furthest thing away from your body, and that's the first to go in terms of priority in your body, right? Result from combination of microvascular and macrovascular disease. So remember we talked about the different types of neuropathy, sensory. So you see this, the risk factors are sensory neuropathy, peripheral artery disease. Other contributing factors, these guys are diabetic, they're smokers, they have clotting abnormalities, impaired immune function, and autonomic neuropathy. They have autonomic, they have sensory, they smoke, they have coagulation problems, double effect. Double effect. All right, next slide. So this is a necrotic toe before and after amputation. Okay, next slide. The complications also are on the skin, all right? So dark, coarse, thickened skin, right? Usually associated with type 1, yellow skin lesions, skin becomes shiny, revealing tiny blood vessels, right? So there are skin changes as well. You should know that. Next slide. Infection. Most people that have diabetes are more susceptible to infection, right? Because there's a defect in the mobilization of inflammatory cells or responses. There's a loss of sensation, which may delay the detection, right? Makes sense. So once we know that they have an infection, we have to treat them promptly and usually more aggressive. Next slide. Diabetes have complication, so those are what we just talked about. Those are the chronic stuff that occur over time. But then you have acute complications. Okay, acute complication of diabetic ketoacidosis, that's one, and then hyperosmolar hypoglycemic syndrome, HHS, or hypoglycemia. Okay, so let's talk about each one of those. So the first one is diabetic ketoacidosis. Diabetic ketoacidosis is caused by profound deficiency of insulin. So this means that someone who has type 1 usually have this type of complication. Type 2, generally you don't, because they have a minimum amount of insulin. So it's characterized by hypoglycemia, ketosis, acidosis, and dehydration. Because remember what I told you, that the glucose is used for energy, and when you don't have ketones, then the fats are breaking down. When the fats are breaking down, you're going to have something called ketone, and then acid builds up. All right? So they'll have something called metabolic acidosis. Okay? It is a life-threatening condition and results in metabolic acidosis, like I said. Next slide. So we need to make sure that the glucose, is telling you how the ketones, this slide is just repeating the information. So when the supply of insulin is insufficient, the glucose cannot be used properly for energy, and then breaks down the fat storage, and then the ketones are byproduct of the fat metabolism. That's correct, right? What are some things that may precipitate someone to get into diabetes ketoacidosis? Well, illnesses, infection, inadequate insulin storage or dosage, undiagnosed type 1 diabetic, that is true, poor self-maintenance, and neglect can put someone at risk. So what are the signs and symptoms? Well, there's lethargy, weakness, which are early, and then dehydration, abdominal pain, there's nausea and vomiting, there's Kussmaul's respiration, that's Kussmaul, respiration. So here what happened is the patient is breathing rapidly because they're trying to reverse the metabolic acidosis that they have. So their breath is sweet, fruity, odor, right? It's very serious, right? Because it must be treated. It's an emergency, all right? Depending on where they are and the symptoms, they may or may not need hospitalization. Next slide. If you do the lab test, remember the normal blood sugar where it should be, this guy's is greater than 300. If you did the pH, remember you did the ABGs, the pH would be less than 7.3. That tells you acidosis, right? The bicarb will be less than 15, right? Normal bicarb is 22 to 26, so that is low bicarb because bicarb is a neutralizer, so it's low, so it's acid. Ketones in the urine and blood. So we need to correct the fluid and electrolyte imbalance. That's what we need to do. So we're going to give IV fluids. Normal saline, 0.45, half normal saline or normal saline, right? When the blood sugar levels approach 250, then we can start adding dextrose in it. right? Because we want to try to prevent hypoglycemia. Potassium is replaced, sodium bicarb is given if the pH is less than 7 to make sure that it's neutralized. Next slide. Make sure that we maintain airway, so there's oxygenation, and insulin therapy. But we can withhold until the fluid resuscitation has begun, and below is followed by, there's an insulin drip that we give. And the insulin that we give is regular insulin, cannot be NPH. Okay? And you cannot mix it with anything else. Next slide. The next complication is hyperosmotic hypoglycemia syndrome. So all of these are hypoglycemia. The question is, who's getting it and what's the level? This is also life-threatening. It's less common than type 2 because it's usually seen in type 2 diabetic. It's less common than DKA. It's usually seen in type 2 diabetic. Often occurs in people that are 6 years of age with type 2, and patient has enough circulating insulin, so the ketoacidosis does not occur, as I said previously, and produce fewer symptoms in early stage. So there are some neurologic manifestation due to the increased osmolality. Next slide. So if you do a history, what do you find? Inadequate fluid intake, increased mental depression, polyuria, because the blood sugars are high, and look at it, it's usually greater than 400, greater than the other one. Increase in serum osmolality, absent or minimum keto bodies, right, because it's not a type 1. And in terms of treatment, though, we're going to treat it like type 1, like DKA, except this requires greater fluid replacement because of greater diuresis, right, because the blood sugar is high. Next slide. So we monitor the patient closely. We administer insulin, IV fluids and electrolytes. We monitor for signs and symptoms of potassium imbalance. We monitor the cardiac rhythm, the vital signs, and the level of consciousness. Next slide. Hypoglycemia is the other acute complication. Hypoglycemia is low level of glucose, right? And it's a complication. So diabetes is high level of blood sugar, and this is low level, and it's usually because of treatment, right? Often occurs when too much insulin in proportion to the glucose in the blood is given. The blood glucose level is less than 70. So how do you know what a common manifestation is? Confusion, irritability, diaphoresis, tremor, hunger, cold and clammy. Next slide. Weakness, visual disturbances. It kind of mimics alcohol intoxication. If it's untreated, it can lead to seizure, coma, and death. So we have to address it. We have to address it. Next slide. So, hypoglycemic unawareness. So, person does not experience warning signs, which can be very dangerous, right? So, it's because they have autonomic neuropathy, right? Just like they don't experience chest pain, right? What are some of the causes of hypoglycemia? Well, mismatch in timing. So the food intake and the peak action of the insulin or oral hypoglycemic agents, there's a mismatch. Right? There's a mismatch. Next slide. So at the first sign that someone has hypoglycemia, we have to check, right? We do a blood sticker, and then if it's 70, then we'll begin. If it's less than 70, then we'll begin treatment. If it's greater than 70, so we can start looking for further signs and symptoms and then monitor them, right? So what is the next slide? What is the treatment of hypoglycemia? Well, it depends on, is the patient responsive? And are they able to take oral supplement or oral intake? So if they're alert enough to swallow, you give 15 to 20 grams of a simple carb, and then give them 4 to 6 ounces of fruit juice and regular soft drink, and avoid food with fat because they decrease absorption of the sugar. Do not overeat. Recheck the blood sugar 15 minutes after the treatment and repeat until the blood sugar goes greater than 70. The patient should eat regularly, schedule a meal to prevent rebound hypoglycemia. And then we're going to check the blood sugar again 45 minutes after that treatment. Next slide. If no improvement after 2 to 3 doses of simple carbs, or the patient is not alert to swallow, then we want to do other things. So we want to administer glucagon, 1 milligram, IM or sub-Q. So you watch for signs and symptoms. Like if you give high blood pressure med, you want to make sure that you watch for hypotension. So in this case, you give sugar, you want to watch for rebound hypoglycemia in this case. That's why we usually follow it by a complex carbohydrate, right? After the recovery. In acute setting, we'll give 20 to 50 mLs of 50% dextrose IV push. All right, next slide. So the nutrition assessment for a patient that's diabetic, it's really important for us to review the past health history, viral infection, the medication that the patient is taking, any recent surgery, positive health history, and obesity. Right? Next slide. Look at weight loss, thirst, hunger, poor wound healing, and Kussmaul's respiration. All the things we've just talked about here. Next slide. Identify some nursing diagnosis and outcome for the patient that have diabetes. Well, these are some of the ones. Ineffective therapeutic regimen management. Yeah, right? Because being compliant is very difficult with diabetes. Risk for injury. Risk for infection. Yes. Powerlessness, the power of not eating what you want. Imbalanced nutrition, more than body requirement. Fluid volume deficit. Tissue perfusion alteration, right? Altered sexual patterns. Remember, it's a disease that affects every system. All right? Next slide. So what are some of the goals for someone who's a diabetic? Overall, you want the patient to have active participation, that they are participating in their well-being. You want them to have fewer episodes of acute hypoglycemic emergencies and hypoglycemia, right? Maintain normal blood glucose level, prevent or delay chronic complication, and lifestyle adjustment with minimal stress. Next slide. So health promotion is big, right? Health promotion for these guys that are diabetic. So identify the people that have a higher risk, and then routine screening for those that are overweight and age over 40. And the screening is usually done by fasting blood sugar, right? Fasting blood sugar. And usually every year, when they go to their primary care, that can be done. Next slide. Acute intervention that we talked about, so hypoglycemia, we've talked about how to treat it. Diabetic ketoacidosis, remember that other acute complication, you know how to treat it. And then hypoosmolar hypoglycemic non-ketotic syndrome. We also figure out how to treat them. They treat it the same, right? Except one has more fluid because of higher blood sugar level. All right, next slide. So some of the acute intervention is stress of illness and surgery. When someone is sick, a lot of patients, they sick, they said, oh, you know what, I'm sick, so therefore I'm not going to eat. Well, when you're sick, your glucose level goes up. So we want them to continue regular meal, and increase the intake of non-caloric fluids, and continue taking oral agents and insulin. So you don't stop taking your drugs because you're not eating. Frequent monitoring of the blood sugar, right? And keto tested if it's greater than 240. Next slide. So again, stress of an illness and surgery. The patient undergoes surgery or radiologic procedure, requires contrast medium, right? The contrast dye, and when that happens, they should hold their metformin. Metformin is an oral drug that is used for diabetes type 2, right? The day of surgery and 48 hours. All right? Because to begin after the serum creatinine has been checked and it's normal because of kidney problems, right? That's why you're holding the metformin. And the contrast dye, that's why you flush your kidneys after you've taken it to make sure that there's no toxicity. Next slide. Ambulatory and home care. The overall goal is to enable the patient or caregiver to reach an optimal level of independence in everything we do, right? The insulin therapy and oral agents, right? And then the personal hygiene. Next slide. So insulin therapy and oral agent, we got to teach them on proper administration, adjustment, and the side effect of each drug. So you should look up all the different drugs for diabetes and which is best for the elderly or not. Assess the patient's response to the therapy, for personal hygiene, regular bathing with emphasis on the foot, remember, for the neuropathy, brushing and flushing, encourage them to inform their dentist about a diagnosis of diabetes. Next slide. So when they are, it's important for them to carry a medical identification and travel card, right? Indicating that they have diabetes, just in case they become unresponsive. We know that it's because they probably have low blood sugar, to replace that or whatever the condition is. Educate them on the disease process, their physical activity, the medications, how to monitor their blood sugar, their diet, any other resources that they may need. And it will enable the patient to become more active participant in their care. Next slide. So goals for diabetic management. So what are the goals? And these are collaborative management. So the goal is we want to decrease the symptoms, right? We don't want the patient to have high blood sugar. We want to promote the well-being. We want to prevent the acute complications, hypoglycemia, diabetic ketoacidosis, hypoosmolar, hypoglycemic syndrome, and delay the onset of complication. Because remember, 10, 20 years later, they have the complication. What we want to do is delay that. Teach them about annual checkups, inspecting their eyes, monitoring their kidneys, monitoring their lower extremities. Next slide. Teach them about self-monitoring of blood sugar. That's really important because a tight control will lower all the adverse effect. Nutritional therapy, counting their calories. There's diabetic ADA diet, and pretty much it's lowering a lot of carbs, right? So white rice, things that have high calorie content, to avoid that. And teaching them about their drug therapy, insulin, how to rotate site to avoid lipodystrophy, how to inject, return demonstration, right? And the different oral drugs, which ones, what they need to do prior to a certain test. Exercise, and that they should carry, sugar, because exercise will lower your blood sugar. So if they plan it, they should be prepared for it. Next slide. Okay, next slide. Drug therapy. All right, so now we're talking about insulin, right? Insulin from an outside source. It's not the natural exogenous insulin. It's not from your own body. Required for type 1, like we said. It's prescribed for clients with type 2 who cannot control the blood sugar by other means. There's different types of insulin. There's human insulin, which is the only type used today, and is prepared through genetic engineering. Next slide. The regimen that closely mimics the insulin production in basal is basal bolus, right? Long acting is basal once a day, and rapid short acting is bolus before meals. Right? So long acting once daily, and then in between is the rapid or short acting insulin. All right. All right, so now we're talking about insulin preparation. Rapid acting bolus comes in different form. Lispro is one of them. The onset is faster, so 0 to 15 minutes it works. Peaks 60 to 90 minutes, and duration is 3 to 4 hours. The short acting is regular insulin. This is, it works not as fast as rapid. It's 30 to 60 minutes, but still faster than NPH. Peaks in 2 to 3 hours, and duration is 3 to 6 hours. Next slide. Intermediate acting, NPH or Lentin, is cloudy, whereas the other two are clear that I just talked about. This is cloudy. Vial must be rolled or rocked a minute of 20 times, put in between your arms and then you roll it. Onset is 2 to 4 hours, peaks in 4 to 10 hours, and duration is 10 to 16 hours. Long-acting basal, Lantus. This one is injected once daily at bedtime or in the morning. Onset is 1 to 2 hours. Duration is 24 hours. No peak action release, steadily and continuously. Cannot be mixed with other insulin. You can mix the intermediate acting with the regular. This one cannot be mixed. Next slide. And this is just pretty much telling you the insulin preparation, rapid acting, and when it peaks, short acting, and the Lantus. You see how it's kind of steady throughout? See how NPH kind of drops. So this is why the endocrinologist is the specialist for insulin, that ensure that the patient has adequate, coverage. Next slide. So insulin storage is important. So we do not want to heat or freeze it. In use, vials may be left at a room temperature. Sometimes you see sitting around up to 4 weeks. Extra insulin should be refrigerated to avoid exposure to direct sunlight. We cannot take it orally because it's subcutaneously, right? Or it can be given IV. Next slide. So the fastest absorption is the abdomen, and then followed by the arm, the thigh, the buttocks. So the abdomen is the preferred site, and we have to teach the patient, to rotate injection within one particular site. Do not inject in a site to be exercised. Absolutely. Next slide. So these are the different subcutaneous sites that you can use. Again, the fastest is the abdomen, right? And then within the abdomen, you can rotate, all right? Within the different sites, you can rotate. Next slide. So administration of insulin, do not inject in a site to be exercised, usually available as 100 units. 1 ml contains 100 units of ml of insulin. No alcohol wipe on site needed before injection. Washing with soap and rinsing with water is adequate. And do not recap the needle ever. We know why. 40 to 90-degree angle depending on the fat thickness, right? Most people are small. I mean, most people can take 90 degrees, but when it comes to insulin, insulin has its own syringe that is used. All right, insulin pump preload with insulin is now available also. Next slide. This is an insulin pump. You know, it has a cap, the plunger, the number, the dial to choose the dosage that you want, and then inject. Next slide. There's insulin pump as well, which is continuous subcutaneous infusion, battery operated device, and it's connected via plastic tubing to catheter inserted into the subcutaneous tissue in the abdominal wall. Right? It has potential for tight glucose control. Next slide. So here's an example or a picture showing it. Next slide. This is an inhale insulin Exbuer. It's rapid action dry powder inhaled through the mouth into the lung. It's not recommended for patients with asthma, bronchitis, or emphysema. Next slide. What are some problems with insulin therapy? Well, some of the things we talked about, but the top one there is hypoglycemia, allergic reaction, lipodystrophy, so thickening of the tissue, Somogyi effect, and down phenomenon. Let's talk about each one of those, the ones we haven't talked about. Somogyi's effect, here you have a rebound effect in which an overdose of insulin causes hypoglycemia. Makes sense, right? But it's usually during the hours of sleep. Counter-regulatory hormones release, and then you have the rebound hypoglycemia and ketosis occur. Next slide. The dawn phenomenon, here you have characterized of hyperglycemia versus hypoglycemia, right? Which present on awakening in the morning. Whereas the other one is usually during sleep, right? So due to the release of the counter-regulation hormones in the pre-dawn hours, growth hormone, cortisol possible effect are what's causing this. All right, so two different phenomena, two different issues. Okay, so controlling how the drug, the amount that you give can help eliminate these issues. Next slide. So the oral agents are not insulin, right? They're not insulin. So we're talking about the drugs now, right? They work to improve the metabolism by which the insulin and glucose are produced and used by the body. So they work on 3 defects of type 2 diabetes. So remember, there was insulin resistance, so the drugs will work to make it more sensitive, decrease insulin production, and also to increase the hepatic glucose production. Next slide. So these are the oral agents in different classifications. All right. Sulfonylureas, barganates, glucosidase inhibitors. So pretty much, next slide. The sulfur drugs are the ones that increase the insulin production from the pancreas. They decrease the chance of prolonged hypoglycemia. So what are some of the names of these? Glucotrol, Amaryl, all right. Next slide. Preden. So insulin here these drugs increase the insulin production from the pancreas. Again, it takes 30 minutes before each meal up to the time of meal. It should not be taken if the meal is skipped. Example of these are Prendin. Next slide. Metformin. This is a glucophage. It's one of the most commonly used drugs, and a lot of people know this. They help reduce the glucose production by the liver, enhance the insulin sensitivity at tissue, and improve the glucose transport into the cells. Do not promote weight gain. Does not promote weight gain. Next slide. And then the inhibitors, these are the starch blockers, pretty much you can say, precoce. They slow down the absorption of carbohydrate in small intestine. Right? Next slide. And then Actos, Avandia, these are drugs that are most effective in those with insulin resistant. So improve insulin sensitivity, transport, and utilization of the target's tissue. And then you have other amylin analog. So these are drugs that help with hormones secreted by the beta cells of the pancreas, co-secreted with insulin, and indicated for type 1 and type 2 diabetic, and can be administered sublingually, subcutaneously in the thigh or abdomen. Slow gastric emptying and reduce postprandial glucagon secretion, which increases satiety. Right. Next slide. Incretin, which mimic sympathetic peptides, stimulate the release of insulin from the beta cells. Sub-Q injections, is given. Byetta is an example of this. So it reduces the food intake and slows the gastric emptying, and it's not to be used with insulin. Next slide. Beta blockers, adrenergic blockers, are also used because these drugs mask the symptoms of hypoglycemia, so prolonged hypoglycemia effect of insulin. The thiazide diuretics can potentiate hypoglycemia by introducing potassium loss. So you gotta be mindful of these drugs. Right, so if your patient is taking beta blockers and they're diabetic, they're going to mask the symptoms of hypoglycemia, which is, you want to know that they have an hypoglycemia. Next slide. Nutritional therapy is the cornerstone of care for clients that have diabetes. It's pretty simple. It's most challenging for people because people like to eat their carbs. Everything around us is carbohydrate, right? So it's recommended the diabetic nurse educator and registered dietitian, do provide a, sit with and, discuss with the team about the nutritional, therapy. Next slide. So American Diabetes Association has its own guideline that indicate that within context of an overall healthy eating plan, persons with diabetes can eat same food as the person who do not. But the amount of it is what difference. Next slide. So overall, American Diabetes Association assists people in making changes in nutrition and exercise habit that would lead to improved metabolic control. Next slide. Meal plans is based on the individual's usual food, and it's very difficult, so that's why you got to know the culture, the kind of food that people use to create. Insulin regimen is managed day to day. Next slide. Type 2, the emphasis is on achieving glucose, lipid, and blood pressure goals and caloric decrease. Next slide. Food composition, nutritional balance of the diabetic diet is essential. So nutritional energy should be balanced without energy output. Next slide. Carbohydrate. Again, carbohydrate and monounsaturated fats should provide 45 to 60% of total energy. So decreased carb diets are not recommended for diabetic. You know, the problem is most of us take more than we should. That's the problem. If we follow the recommended diet, then we'll be in line. Next slide. Glycemic index, term used to describe the raise in the blood glucose level after consuming carbohydrate containing food, should be considered when formulating a meal plan. That's right, should be. Next slide. So fat, it says no more than 20 to 35% of the meal should come from total calories. So that's less than 7% from saturated fat. So for the glycemic fat, you got to look calories or carbs. You got to look for food that don't have a lot of glycemic index, like brown rice versus white rice. Next slide. Protein contributes to less than 10% of total energy consumption. Intake should be significantly less than the general population in a diabetic. Next slide. Alcohol is high in calories. It doesn't have any nutritional value. It promotes hypertriglyceride, detrimental effect on the liver, and can cause severe hypoglycemia. So the diabetic should not be drinking too much. Next slide. So teaching is important. So dietitian initially provides instruction, should include patient's family and other significant others, because they cannot just be on the diet. Everyone has to be in, everyone should be supported. Right? The plate method, would help the patient visualize the amount of vegetables, starch, and meat that should fill in a 9-inch plate. The pyramid, the My Plate, right? So it's important for us to talk nutritional support. Next slide. Exercise. It's an essential part of diabetes management. Increase insulin receptor site and lower the blood sugar levels and contribute to weight loss. So it is good for us in them. Next slide. Several small carb snacks should be taken every 30 minutes during an exercise to prevent hypoglycemia. It's best done after meal, and exercise plans should be started after medical clearance, slowly with gradual progression. Next slide. Should be individualized, that's right, and monitor blood sugar before, during, and after exercise. Next slide. Self-monitoring of blood sugar is also very important. It enables the patient to be involved in their care, right? So they know what their blood sugar is. So diet, exercise, and medication, they will see how that is helping, whatever they're doing is helping control the elevated blood sugar. Next slide. It's important for detecting episodic hypoglycemia and hypoglycemia, right? And patient training is crucial and how to do it. And it supplies immediate information about their blood sugar level. Next slide. There's different ways, and it's available at CVS, and it's showing you the different types, some of the types that are used to monitor the blood sugar. Next slide. So there is pancreatic transplantation. So it's used for clients with type 1 diabetes who have end-stage renal disease, had or plan to have a kidney transplant. Next slide. So pancreas transplants alone are rare. Usually kidney and pancreas are done together. It eliminates the need for insulin because it can also eliminate hypoglycemia because if we give you a better, a healthy pancreas, then the beta cells are going to make insulin. Next slide. So, what are some of the nutrition management in terms of evaluation? Because remember the nutrition process. This is the last step. So, we're going to evaluate the knowledge. We're going to evaluate the nutrition, their immune status, their health benefits, and we're going to evaluate to see if there's any injuries that they have, right? Because if they're compliant and they're following their nutritional therapy, they are healthy and no injuries, then the goal was met, right? Next slide. So these are some of the skin conditions that you may see with diabetes. Next slide. Gerontological consideration is also very important. Diabetes is prevalent with age. Hypoglycemia unawareness, it's more common with these guys. And because of delayed psychomotor function, could also interfere in treating their hypoglycemia. And the most consider patient's own desire for treatment and coexisting medical problems can also complicate something else, the diabetes process. Next slide. Also recognize the limitation in their physical activity, their dexterity, and their visual acuity. All of that can complicate the disease. So education is based on individuals' needs using slow pace. That ends the lecture for the endocrine system. Thank you. No.